The diagnosis of exclusion. You have to rule other likely culprits out first.
So where does the investigation begin?
It always starts with the patient history. That is absolutely critical. Has the person lived in or traveled extensively to an endemic region? That's the first most important clue. Without that geographical link, tropical sprue is way down the list of possibilities.
Makes sense. Okay, after the history. Labs, I assume.
Yes. Laboratory findings are next. Blood tests are crucial. They'll look for that macrocytic anemia we talked about, low hemoglobin but high MCV, meaning large red cells.
Confirming the folate and B12 issue?
Exactly. They'll measure serum folate and B12 levels, which will typically be low. They'll also check albumin levels. Low albumin points to protein malabsorption. You might also see low calcium, low vitamin D, maybe problems with blood clotting time due to vitamin K issues.
Any specific tests for the malabsorption itself?
Yes, a really important one is the D-xylose absorption test. D-xylose is a sugar the upper small bowel should absorb easily. You drink it, and doctors measure how much comes out in your urine over a few hours. If not much comes out, it means the upper bowel isn't absorbing it properly.
A functional test of the gut lining.
Precisely. And to specifically confirm fat malabsorption, the gold standard, though cumbersome, is a 72-hour fecal fat collection. If you're excreting more than about 7 grams of fat per day, that's abnormal.
Okay, so labs point towards it. What's the definitive diagnostic step to actually see the damage?
That requires looking directly at the tissue. An EGD esophagogastroduodenoscopy with small bowel biopsies is the key.
So an endoscopy where they take little tissue samples?
Exactly. They take biopsies from the duodenum and, importantly, the jejunum. Then the pathologist looks at them under the microscope for the characteristic histological findings.
Which are?
Partial to potentially total villus atrophy, those flattened villi. Crypt hyperplasia, the little glands between the villi get longer, trying to compensate, and increased inflammatory cells, lymphocytes, plasma cells packed into the tissue layer beneath the surface, the lamina propria. It shows the ongoing inflammation.
But you mentioned a catch earlier. These changes look like something else too.
Yes, and this is absolutely crucial. These histological changes are not specific to tropical sprue. They look very similar, almost identical sometimes, to celiac disease.
So how do you tell them apart?
This is where everything else comes together. The travel history is essential, and you need negative celiac serology. Blood tests for celiac antibodies like TTG-IgA must be negative. If those are positive, it's celiac. If negative and the travel history fits, then you strongly consider tropical sprue.
So